Do a bit of an introduction, then we'll introduce our speaker in a few minutes here. But I did want to say good morning, everyone, and welcome to our Waypoint Talks series. It's my pleasure to welcome you to our fourth one of the year, and we're really excited to present to you today on some of our implementation science work that's happening within our research institute. If this is the first time that you've joined one of our Waypoint Talks series, I'd like to remind you that the Waypoint Research Institute is an embedded unit within a specialty mental health hospital setting. We conduct research in many areas, including forensic mental health, implementation science, child and youth mental health, and substance use. The WRI is comprised of over 40 staff and students now, including support staff, research scientists, clinician scientists, and other researchers who are with us through scholarships and academic appointments. Next slide, please. But before we get going today, I would like to first acknowledge that the Waypoint Research Institute is located on the traditional territory of the Anishinaabe, which includes the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy, the Haudenosaunee, Huron, Wendat, and Métis peoples. We would like to acknowledge and affirm our commitment to improving relationships between nations and to improving equity for Indigenous communities residing in the central north region of Ontario. And we also invite you to share the traditional territory you are joining us from. If you're unsure of which territory that might be, we encourage you to look at native-land.ca. That's native.land.ca, and it will list the territories on which you reside. A reminder that Waypoint Talk series, as I mentioned at the outset, is a webinar series aiming to highlight the practical implications of our research projects. And today we're focusing on a second part of our series, which is building a research toolkit, which is a virtual education series aimed at highlighting best practices in mental health, including quality improvement and program implementation. And you'll hear from John in a few minutes about some of his work in that area and some of his expertise that he does in his own program of work, and then helps with capacity building within our team and the hospital. A few housekeeping notes. So you've probably been on a million Zoom calls over the last few years, but just in case you haven't heard yet, that you can join the chat in the box or the Q&A function at the bottom of the screen if you want to connect with the speakers or you want to ask questions. So please don't hesitate to use the chat box and use the Q&A function if you have questions throughout. There will also be a question period at the end where you can raise your hand and ask questions as well. The recording and the slides of this webinar will be available on our website after the event, so we encourage you to look back, and we have recordings from all of our past Waypoint Talk series that you can access as well. And we also love to hear from you about how we're doing with the webinar series, what we can improve on and improve for the future. So if you have any suggestions for that, we'll send out a survey towards the end of the event as well with the recording, and we'd love your feedback. And if you're here participating as part of professional development, we do offer certificates of completion or certificates of attendance. So if you have any questions about that, by all means, send us an email and we'll get those off to you. Okay, most importantly, the feature of the day, as I mentioned, is our research scientist, Dr. Zhengsheng Zhao. He joined the Waypoint Research Institute as a research scientist in early 2023, so just over a year ago now. He has an impressive research expertise in implementation science, integrated knowledge translation, co-production, and most recently, SCIHR funded in shared decision-making. He approaches his work through a lens of behavioral science and complexity system approaches. His methodological expertise includes realist approaches, qualitative study, mixed methods, systematic reviews, and complex system approaches for intervention, development, and evaluation. John was hired, as I mentioned, a year ago to help build capacity in implementation science. And we talk a lot about this in our hospital and our region about the need for implementation science and practice expertise. And so we're really excited to welcome John here to present to you, and I will pass it over to him. And as a reminder, if you have questions throughout, please don't hesitate to drop them in the Q&A box. And we'll have a discussion period at the end that will be facilitated by Christy. Over to you, John. Thanks.
Thank you, Christopher. Let me to share my screen. Oops. Okay, good morning, everyone. I'm Junqiang. Thank you for I can't see that. Sorry, wait one moment. Oh, can you see my slides now?
We also see the presenter slides, John. The first version you had up did not show the presenter view.
Oh, I can't.
If you go display settings, maybe.
Display. Sorry. Okay, now I try to. How about now?
That's it. Perfect.
Okay, good morning, everyone. Thank you, Christopher, for the introduction. Today I will talk about implementation science and quality improvement. So I will have a brief introduction of these two concepts and share with you some of my thoughts on how we can embed implementation science theories, methodologies, or tools into our QI initiatives. Before my talk, I should acknowledge that my expertise is more on the implementation science aspect, not the QI aspect. So that's why my presentation topic is embed implementing science to QI. But that doesn't mean implementing science is superior than QI. I think these two are complementary and should be collaborative to promote our healthcare work. So maybe in the future, some of our QI experts could think of give a presentation on how to embed QI in implementation science. So that will be also very interesting topic. So before we start, I'd like to have two poll questions to have a basic understanding of our audience, like your knowledge of implementation science. I think Jessica, you have the poll questions. So the first one is just, have you heard of implementation science before? Jessica, how long should I wait, or it will show the results automatically?
I think we're just about there. We have 39 of 40 participants. So your results currently, as you're seeing it, should be accurate.
Mm. Mm. Okay, can we see the results now? Okay, nice. We have 87% of our participants have heard of the implementing science, no matter its term or know the field. I think that's great. I think implementing science has become a buzzword in our current healthcare research and practice, and has been gradually embedded into our clinical work. So that's great. The second question is about your level of expertise in implementation science, whether you are new to this field or whether you have maybe advanced knowledge of its methods, its theories, or its the whole field to get a sense of our audience expertise. Okay, maybe we can take a look of the results.
Sure.
Nice. We have, I think, a diverse population here. Half of our participants are new to this field, are beginner, and some are intermediate, and some are advanced. And we also see 8 people know nothing about implementing science. So I hope in my today's presentation, I have provided some theoretical level knowledge about implementation science, and also some practical tools that could help us to do some QI work. I hope could meet with the needs of our audience today. So one of our most consistent findings in our current clinical and health service research is no longer the effectiveness of interventions. We have identified a lot of effective interventions in our current health research. The most challenging part has become how to translate those effective research interventions into our practice and policy. So this is a challenging part in our current clinical research. So that's the background of our implementation science. It's about the scientific study of methods and strategies to facilitate the uptake of evidence-based practice into our everyday practice. So here are we have some key terms that we should pay attention and are very key to implementation. First is the uptake of evidence-based practice. When we say we are doing an implementation research, we should always think, do we have an evidence-based practice at hand so that we could consider to promote its uptake by our practitioners and the policymakers. So it's an uptake of evidence-based practice. But nowadays, we seem to have expanded the implementation science, the scope of implementation science. We not only focus on the evidence-based practice now. Sometimes we may focus on the innovative practice. We also want it to be implemented in our setting. So some innovative practice, also maybe some policies. Some may be evidence-based policy, but some maybe not. So the scope of implementing science is expanded, but mostly we focus on evidence-based practice uptake. So implementing science has been interchangeably used with other terms like launch, translation, mobilization, uptake, utilization, research use. Some experts have tried to distinguish those terms, but I think they share the same goal and has been used interchangeably in our literature. And in different countries, they seem to use different terms. Like in Canada, CIHR often use the term launch translation, and now it seems to change to launch mobilization. And in the state, they often use dissemination and implementation science or just implementation science. So those are the terms that we often use interchangeably with implementation science. So here are some very commonly used terms in implementation science that how we can translate into our everyday words. So first, the intervention, the evidence-based practice, or the innovation, or the policy, we can just refer it to the thing that we wanted to be uptake. So effectively study looks at whether the thing works. It reminds me of an activity we held in our yesterday's WRI monthly meeting. We shared something that is unknown to our group. So I shared that I played, I like playing mahjong. So I see in the literature that playing mahjong has the potential to prevent Alzheimer's disease in the elderly people. So if we conduct an effective study, then it's look at whether playing mahjong could work to prevent Alzheimer's disease in older adults. So the same is playing mahjong. Effective study is about whether playing mahjong could reduce the incidence of Alzheimer's disease. And implementation science look at how best to help people do that thing. Again, we collect to the playing mahjong thing. So then implementation science is how, if we establish the effectiveness of playing mahjong, that we can if we confirm that playing mahjong could prevent Alzheimer's disease, then implementing science is that, okay, how can we promote the older adults to play mahjong, to promote them to playing mahjong. Then we should think of some implementation strategies. The stuff we do, try to help people do the thing. We should think of some strategies. Okay, playing mahjong is effective. How can we promote older people to play mahjong? Maybe in our community centers, we could buy some mahjong and give instructions to older adults on playing mahjong. So those might be our implementation strategies to promote its uptake in older adults. So that's the implementation strategy. And this is one of the key terms that we often use in our presentation on implementation science, the implementation strategy. So implementation outcomes are how much and how well they do the thing. So for playing mahjong, then when we evaluate the outcome, like did the older adults play the mahjong at all, or how frequently they play the mahjong? So that's a key outcome we want to focus on. But there's also some additional outcome, like do they sustain the behavior, etc. So that's the several key terms that we could translate into our everyday language. And then we often see accompanying with implementation science is implementation research. We often see that we are going to do an implementation research. What is the position of implementation research in our research pipeline or pathway? Here's a diagram to generally illustrate it. Just a brief introduction. So we could, at the very beginning of our research, we could do some pre-intervention research. That's the basic science lab research. We do it with cells or mouse to establish, okay, whether an intervention or could an intervention works at all. If it works in the labs or mouse, then we move it to humans. We conduct some rigorous or explanatory trials. We see randomized control trials to see whether the intervention works in a very controlled settings. Again, maybe the mahjong example, we have a highly restricted eligibility criteria, highly restricted sample population to see whether it's to establish efficacy, whether it's effective in control setting. If it's effective, then we move it to the real world setting to expand the eligibility criteria to have more, to make the study setting more close to our real world setting to see whether it's effective in our real world setting. If the intervention is effective, then we consider to do an implementation research to promote its uptake. So again, implementation research is after we establish the effectiveness of an intervention, then we consider its implementation. So in implementation science, there are a lot of achievements. One of the particular achievements is the development and the use of theories to promote implementation. So this is a popular diagram to categorize the theoretical frameworks we often use in implementation. First thing we see the process models. Those are the models that give us step-by-step guidance on how to do implementation. So those are the process models. And the second category are with determined frameworks. Or those frameworks can help us assess the barriers and the facilitators for doing implementation. We could those three determinant framework, classic theory or implementation theories, all serve the purpose, understand in explain what are the factors influencing the implementation. We could also have frameworks that assist us to do the evaluate the outcomes. So those are the three general categories in implementation theory. And we will, in our later part, we will share it in details, how we could embed it into our QR work. So here is another formula for our successful implementation. If we want to implement something successfully, three key components that we should have effective intervention or innovations, and then effective implementation and enabling context. So when we do implementation, we will always consider the three components, whether the intervention we selected are evidence-based, whether we have effective implementation strategies, whether our local context, organizational context provider can facilitate our implementation. So that's the three components to promote implementation success. So this is some basic, just basic knowledge about implementation science. To give a brief introduction of this field, so I may take a pause here to see any of you have any thoughts or questions on implementation science. And feel free to raise your hand or post it in Q&A. I can wait for 30 seconds and I can answer it right now or later at our very end.
Zhencheng, I noticed that Jenna Weck has her hand up. Jenna,
Yeah.
are you able to post your question in the chat, or would you prefer to do it live? Oh, we have a couple of other raised hands. Just a moment, Zhencheng, and I'll engage them here. There. Okay, Jenna, go ahead.
Okay, I see one question from Seville. How does one decide which theory to use when doing? I think this is a really great question. I feel there's no right or wrong which theory to choose. There are multiple factors we could consider. Firstly, our own understanding of the theory, whether we should first understand those theory, whether the theory is the one we understand, and whether the theory matches with our clinical context. It fits with the question that we are trying to answer. And the complexities of the theory, I think there's no right and wrong answer, and then our clinical question that we try to answer. That's the true. And later I have some specific examples of theories we can choose from. I think it depends on which one resonated with you.
Thanks, John. I have one more person. I'm just going to unmute Jenna.
I didn't hear the.
Sorry, Jenna, if you can hear us, I'm allowing the talk function. It may require you just to accept that.
In terms of, here's one. In terms of implementing science with respect to Waypoint, what is the process of using latest evidence-based practice with our work? I think this is one very important question. I would say that it's a collaborative work. It's a collaborative work between our clinical staff and researchers, and maybe particularly implementation science researchers. For example, we want to identify the rigorous and effectively interventions before implementation. So that's a part collaborative work between our maybe librarian and implementation scientist to do the work together. And for later implementation, how we develop the implementation strategies. This is, I think, the key and the complex part that that is a collaborative work between our scientists, clinical staff, and frontline workers. So I think collaborative work between stakeholder and knowledge users. And Okay, thank you for these questions. Maybe we should proceed and feel free to post your question in Q&A. So that's a brief introduction of implementation science. And next, the quality improvement. Again, this is not my content expertise. I should just give you a brief introduction of it. So quality improvement is a continuous and ongoing effort to achieve measurable improvements in our clinical practice. It's often local. We do not try to generate generalizable knowledge and do not try to spread it in other settings. We could use various QI tools to promote the practice like PDC Circle, Lean Six Sigma, or experience-based co-design. Recently, one popular tool model is the model for improvement that commonly used in our QI work, which should firstly clarify the aim. What are we trying to achieve in our QI work, and the outcome? How well we know a change is an improvement, and what change can we make that results in improvement? So we could use the PDSA circle to iteratively to promote the clinical quality improvement. So what do we mean by quality when we always see quality improvement? There are 6 key components of quality. That is, I think, maybe universally accepted, and this is also accepted by the WHO. Quality means it should be first safe, effective, patient-centered, timely, efficient, and equitable. So nowadays, there has been calls to promote quality improvement as an improvement science, because more and more research literature have identified that many of our local quality improvement initiatives fails to meet its goal, are suboptimal. It's either some of the QI initiative, as it's mentioned here, it's laser informed by high quality evidence, nor is subject to rigorous assessment to establish its effectiveness. So improvement science is about to find out how to improve and make change in the most effective way. The goal is to ensure our QI efforts are based on as much on evidence as possible. Some terms that have been used to refer to improvement science is a science of improvement and implementation science or translation research, etc. So from these terms, we could see that sometimes we use implementation science and improvement science interchangeably in our literature. So that's a very brief introduction of implementation science and quality improvement or improvement science. We can think here. We can think what's your thoughts on the collections between implementation science and quality improvement or improvement science? Maybe you can put it in the chat box, and or people can say it. And for the time consideration, I may proceed here, but feel free to share your thoughts in the chat box. So here is a Venn diagram to illustrate the relationship between QI and implementation. So implementation research and quality improvement science are all under the umbrella term of delivery science, which is a systematic study of healthcare delivery. And those two, when we do implementation practice or QI practice, we always draw the science aspect of these two fields. But generally, those 4 fields are so closely connected and there are not overlaps between them 4. In terms of the similarities and differences between those 2 fields, I have a table. It's a little bit busy, but we can simplify it. So firstly, about the origin of this 2 fields. They are all concerned about the practice change. They are all action-related, change-oriented. They draw a lot of aspects from psychology, particularly behavioral psychology. They have different origins. Implementation science mostly come from the evidence-based practice movement. Improvement science are mostly from the management and manufacturing field. In terms of the more ontological, epistemological, and methodology field, they are highly applied field. They always try to find solutions to our actual clinical problem, so are highly applied in nature. In terms of problem identification, there's always a gap that we try to bridge for both implementation and improvement science. But implementation science, the problem relates to a delay in getting the effective practice into our clinical work. We have a lot of established interventions, but they are in the library, in the shelf, do not get a use, so we try to promote its use. Improvement science is related to the efficiency, safety of quality concerns of our clinical practice. Then potential solution, they share multiple common strategies in tackle the problem. Implementation science, they often implement the evidence-based practice to promote the use of evidence practice. Improvement science often think about the change in the healthcare system or process to promote to address the clinical problem. They also use analytical tools. Implementation science use a lot of theories, models, or frameworks that I will share later. Improvement science use a lot of QI tools. Knowledge production, both emphasize generate applicable knowledge for local context. Meanwhile, generalizable knowledge that can be contribute to the scientific knowledge community. But healthcare professionals or knowledge organizers, developers, maybe have more knowledge on the QI or improve the knowledge than implementation science. So that's the general introduction of the differences and similarities between those two terms, but feel free to share your thoughts. So in WHO 2021 and 2030 Global Patient Safety Action Plan, it provides 7 guiding principles to promote patient safety. The first one, engage patients and families as partner in safe care. This is, I think Waypoint has did very great in our work. We have PCFC involved in every aspect of our practice or research work. And again, collaborative work. As I mentioned, the change initiative is always a collaborative work between researchers and practitioners and the various knowledge users. And then one important aspect is translate evidence into actionable and measurable improvement. We should embed the implementing science knowledge into our patient safety practices. So this is one key guiding principle suggested by WHO for patient safety. We also have other guiding principles. So how can we align implementation science with improvement practice? There are some challenges. Firstly, we use different terminologies, different models and methods, and focus on generalizable versus local knowledge. Sometimes they compete with each other when we try to, like implementing science, when we try to generalize our knowledge, then it's sometimes challenging to apply the knowledge into our local context. And then limit the evidence in support of the effectiveness of improvement tools. Then how can we align these two fields? Again, firstly, partnership, research and practice partnership, local ownership of implementation. QI initiative or implementation practice should always lead by the local practitioners, by our clinical staff. Our implementation scientists may play a supportive role to facilitate the implementation rather than ownership. The ownership is our frontline workers, so that we can have their voice, have their agency in the practice work, generate practice-based evidence. Not only we should find the research evidence to support clinical QR work, but also practice-based evidence that is generated by our years of clinical practice, clinical wisdom, and develop context-specific implementation strategies and the practice level capacity. So that's some strategies we could align this to field. So here's a flow diagram to illustrate the circle of doing a change initiative and the relationship between QI and implementation research. So our QI work often starts at the first phase, try to identify the problem. Try to identify a problem. Then we try to find a solution to the problem. But implementation research, implementing practice often starts with a solution. We already have the solution here, and our goal is to promote the implementation of the solution. And then we prepare for implementation, implement the solution, and consider the spread of the solution, but QI don't necessarily leave that, and then consider the sustainment. So here, the diagram, I think two key aspects is that our QI initiative starts with a problem, and we need to find a solution. But implementing research often have a solution at hand. Implementing research emphasizes not on the spread and scale of our work, but QI don't necessarily focus on that. So how can we embed implementation science to quality improvement? Just now in the introduction of implementing science, I mentioned a term, process models. That give us step-by-step guidance on how to do implementation. So this 4 steps model actually is a process model. It gave us guidance on how to do implementation. Who needs to do what differently? Use a theoretical framework to assess barrier facilitators, develop implementation strategies, and measure the behavior change. So those 4 steps are commonly used in implementation science to guide our implementation work. And we can try to embed those 4 steps into our QI initiatives, into our PDSA. In our planning stage, after we identify the solution, maybe we do not need to directly go to the do stage. We further need to clarify who needs to do what differently. At the do stage, we use theoretical frameworks to assess if we want to do the practice, what barriers we might encounter, and we generate a strategy to address the barriers. And at the study phase, we use some frameworks, we use some measures to measure the achievements, and then action to do the evidence-based practice. So that's my understanding on how we can possibly embed the implementation into our QI work. So maybe we can see it in step by step. At the planning stage, after we identify the effective solution, we should further clarify, okay, this is our solution. Who needs to do what in terms of differently in terms of for the solution? Here is a framework named the AACTT framework that could help us specify the behavior. This is a very easy to operate framework, but super useful in our later barrier assessment and outcome evaluation. Action is what are the specific behavior that we want to perform. Actors who will do the behavior, who will do the action. Context at where. Target who will receive the action. Time at what time we should do the action. So here is one example about increased physician hand hygiene compliance. We could take this example to see how we could apply this AACTT framework. So the action might be washing hand with soap or water. Actors, staff physicians and residents. Context is a medical surgical ward at a specific hospital. Targeted patients. Time is before, after patient context. So this is only one behavior in this QI initiative, in this hand hygiene initiative. But actually, this small initiative might involve multiple behaviors. As we mentioned, for the staff physician, they use soap or water, alcohol-based hand gel, but it also involves several other behaviors, involve other actors. For example, cleaning staff check and refill the gel dispensers, and hospital administrators order the gel and the dispensers. So from here, we could realize that even such a simple QI initiative, it involves multiple behaviors, involve multiple actors. So maybe it could inspire us that maybe sometimes when we do a QI initiative, start small. Even a small initiative involve sometimes complex behaviors, involve multiple actors, multiple actions. So that's the first stage. Use this simple framework, AACTT framework, to specify the behaviors in our QI initiative and clarify the responsibilities. Okay, you need to do this. You need to do that. So specify the behavior and clarify responsibilities. Then at the due stage, after we specify who needs to do what, we should consider, okay, if the physicians use the soap before contact the patient, what kind of possible barriers would we encounter to do this? We could use some theoretical frameworks to assist us to assess the barriers and the facilitators. In our traditional approach, we often use it seems like a good idea at the time principle, like we just do the education. It works at somewhere else, so we use it here, or it's just common sense. So that's the traditional approach when we assess the barrier facilitators. But when we do implementation, evidence-based practice, evidence-based medicine should be complemented by evidence-based implementation. We should use some more rigorous approach to assess the barriers. Use some theoretical frameworks. Sometimes those frameworks could help us to identify some unexpected or surprising barriers that we may not realize. So here are some commonly used frameworks for assessing barriers. Firstly, theoretical domain framework and a COMB framework. These two frameworks are closely connected. For the TDF, this framework is developed by a synthesis of 33 frameworks in health behaviors, like I think 128 constructs, and then distilled into those 14 constructs that could explain health-related behavior. Those 14 constructs that could explain why we have this behavior or that behavior. So, and then their team, Susamichi, their team, further developed the COMB framework, capability, motivation, and opportunity. They map the TDF constructs into those 3 dimensions. Map the largest scales memory, behavior regulation to capacity, and this 8 to motivation, and this 2 to opportunity. So these 2 frameworks are closely collected to help explain our health behavior. So let's look at in detail of the COMB framework. COMB framework argues that our behavior is the results of the interaction between capacity, motivation, and opportunity. When we want to change the behavior, we should always consider, okay, whether is it a capacity problem, or is it the motivation, or is it a opportunity? So capacity, we involve psychological, maybe capacity, we have psychological capacity. It involves our knowledge, our psychological strengths and skills, or physical capacity, our physical strength maybe. Opportunity, we also have two subdimensions. Physical opportunity, like time, resource, like social opportunity, the cultural norms, social factors. Motivation that has reflective motivation, automatic motivation, our reflection process, making plans or evaluate things that have happened. Later we have some examples. Automatic motivation, our habit, our desire. So those, this is a COMB framework. Then let's collect it with the hand hygiene initiative. If we want to assess, okay, what are the barriers in physicians to do the hand hygiene work? We could use the COMB framework to do some interviews with physicians. We could, for the capacity aspect, we could say, okay, how confident do you feel in your knowledge of hand hygiene? Physical capacity, what resource or trainings would you find helpful in improve the hand hygiene? Opportunity, are there enough access of hand hygiene stations? Social opportunity, how does your colleagues or supervisors influence your hand hygiene practice? Motivation, what's your personal beliefs or attitude towards this practice? Are there any routine practice or habit that contribute or hinder the practice? So we could use this framework to help assess the barriers. And then theoretical domain framework. As I mentioned, this framework is closely related to COMB, but be more specific. They have 14 domains. Here are some sample questions for each domain. Again, we can use the hand hygiene example. Do you know how to do hand hygiene? That's a knowledge. Sometimes we do not necessarily to ask all the questions in the 14 domain. Some are closely collected, so we might choose one of, for example, knowledge skills are collected, we might choose one of them. Like memory, is hand hygiene something you usually do? Or do you have a system that monitor the hand hygiene practice, behavior regulation? How difficult is it, or how easy is it to do hand hygiene? Let's believe about capacity. Beliefs about consequence. What do you think will happen if you do or do not do hand hygiene? So we could use those interview questions, or also sometimes we could use surveys to identify what aspects of our of those 14 behavioral determinants could are influencing we do the hand hygiene. So that's a theoretical domain framework. Another framework is the consolidated framework for implementation research. It has two versions. Now it's updated to the second version. It has five constructs, I should say 5 domains: individual domain, inner setting domain, outer setting domain, implementation process, or the innovation. We could also use survey or interviews to help us understand in which domain and even in which specific construct. In each domain, they have specific construct. In which domain or specific construct influencing our doing of the practice. Again, survey or interviews, both okay. Sometimes when we do the interview, we could first and broadly to see, okay, what do you think in our organization that might influence we use the hand hygiene? And we also can probe into specific areas in these specific constructs. So that's a consolidated framework for implementation research. We could see from those, well, what barriers in those 5 categories influencing our implementation. We also have I-Paris framework. It argues that a successful implementation relies on the facilitation of 3 constructs: the innovation, recipients, and the context. We could also use survey or interview to see which construct might influence our behavioral change. And then auto mode of research use, we also have some constructs here that could guide us to do the barrier assessment. So overall, there are multiple frameworks, existing frameworks, and well-established frameworks that could help us to do the assessment. COMB, TDF, CIFAR, IPARIS, or other frameworks to help us to assess barriers. Maybe I can stop here to see whether we have some questions here. So here's one question. Does quality improvement often always refer to improvement of a clinical policy or practice? Can it refer to improvement in research practice as well? That's an interesting point. I think it can be, but I guess in the research field, we do not use the term quality improvement, but like we use how to improve the rigor of our research process, improve the rigor or methodological quality of our research work. With recent development in AI, does Waypoint use AI to assist with? Wow, that's a novel field. I do not have much knowledge in AI, but definitely just in this month, in the Journal Implementing Science. So this is the most influential journal in our field. They just published one paper on how to embed AI into implementation. So I will definitely take a look at this paper, and you also can take a look at that paper. This is really new and very interesting field, but no, I do not have any knowledge in this. Okay, thank you for those questions. Maybe we should proceed, and again, feel free to post any further questions. Okay, so the next phase is to develop implementation strategies. There's already 1 hour now. So this is the most complex and challenging part in our no matter implementation work or QI work. There's no magic bullet, and our implementing strategy development should consider a lot of factors: the diagnostic assessment of barriers, our understanding of mechanism of actions, empirical evidence about effect, and engage stakeholders and available resources. So here's one 3-step approach in the implementing science field that we develop an implementation strategy. Barrier assessment that we have mentioned previously, and then select an intervention function, then develop implementation strategies. Intervention function is the underlying function of the change strategies that could serve. We could think of it as the purpose of a change strategy. So this 3-step barrier assessment and select. We map the barriers to a specific intervention function, and map the intervention function to a specific implementation strategy. It's a little bit complicated, but I will try to illustrate it clearly. So here's one behavior change wheel, again developed by the Susan Leach, their team in UK. They mapped if you remember this framework, COMB framework, they map it to intervention functions. If we want to change the clinical practice, they mapped it into various implementation functions. If we want to change the policy, they further map it to policy level, but we only focus on the clinical level. So the middle circle, they map the capacity into 3 intervention function and motivation additional 3. So we can see this totally, I think it's 9 intervention functions: education, persuasion, incentivization, enabling, training, coercion, restriction, modeling, environmental reconstruction. So those are the intervention functions that has been summarized in our in our change intervention implementation strategy, that the purpose of our implementation strategies, we could categorize them into those 9 intervention functions. So in our previous step, in our COMBI work, we could identify, okay, maybe it's the physical capacity, maybe it's our skills, that we lack skills. We could map it to the training function. Maybe it's our knowledge, we could do education. So basically, their team map the barriers, identify barriers into those 9 intervention functions. When we identify which aspect, the barriers in which aspect, we could consider which intervention function we might use to address this barrier. So this is a map of the barrier with intervention function. Then, again, I mentioned that COMBI is closely connected with TDF, though they are basically connected. So we could also specify, okay, in those specific TDF domains, if knowledge, like knowledge, we could do education, we could do enabling. If it's beliefs about capacity, we could do a coercion or education. Again, it's about map the barriers into the specific intervention function. So those maps are not just arbitrarily did. They are did based on the thorough systematic review and the Delphi study. They developed the map, so it's evidence-based. So if we use TDF or COMBI to do our assessment, we identify some aspects of barriers, we could consider to use some intervention functions identified here to develop our implementation strategies. So map the barriers to intervention functions. Then we have quite a lot of implementation strategies developed in the behavioral science field. For example, so those are the specific behavioral change techniques that we can, a lot of behavioral change techniques that we can use to change our behavior. So we could map, again, we could map those intervention functions with implementation strategies. So barrier assessment to intervention function to implementation strategies. So how to do the further map of implementation intervention function with strategies? So here are some online tools that could help us to do the mapping work. So for example, the Center for Implementation, they have a strategies tool. If we click this, okay, we identify that we lack knowledge, we click knowledge, then it shares with us that, okay, if we lack knowledge, we could use the intervention function of education. We click it, okay. In the education, we have multiple implementation strategies that we can use to promote practice change. So that's a map from the function to implementation strategies. So this is one tool that we can use. Again, it's a little bit daunting. We identify the barrier, we map it to the function, education. In the big function, we have a lot of strategies we can turn to change the practice. So this is one tool that we can use. Another, and in this, and in their website, if you you can also download the strategic tool worksheet. This also provides you step-by-step guidance to do the work. And also there are some additional additional online tools that we can use to do the work. So this one, we search in Google theory and technical tools. we search it in Google, then we could identify a website that collects the various behavior change techniques with our barriers. For example, if we identify that we lack knowledge, we can see what strategies we can use to address it. So here are the links. If it's a link, it implies that there are explicit evidence linked to it. So we want to see which strategy we can use to address knowledge. We try to find the green link. Okay, maybe this one, biofeedback. Maybe here to provide a detailed explanation of it and instruction how to perform the behavior. If we lack skills, again, we can see, okay, instruction of how to perform the behavior is the strategy we might use. So this is also a very interactive tool that we can use in our selection of implementation strategies. So, and also their team have developed an app named BCT Taxonomy. You could identify all the implementation strategies and how they map to the intervention functions. Very easy to use. You can turn to all those resources to guide the choice of implementation strategies. So that's mostly from the behavioral science aspect. I know it's when you first see it, it seems a little bit daunting. Just remember, do the assessment, map it to intervention function, and then map it to strategies. You do not need to remember the specific function or specific strategy. Those online tools can assist you to find those functions and strategies. And we implement scientists are here to help. But I should say that develop implementing strategy, those are from behavioral science aspect. Those are popular and well-studied, and these are what I mentioned have strong literature support. So they are well-studied, but it's not the only way to develop implementation strategies. And there are also critiques about developing implementation strategy using this approach, like it mostly focuses on the individual behavior change aspect, maybe not a collective aspect. So this is one, I should say, popular way and a well-established way, but not the only way to develop implementation strategy. We also have some other approaches. I will quickly share it. For example, if we use CIFAR to do the analysis of barriers, their team have developed an ERIC taxonomy to categorize all possible implementation strategies into those underlying categories. And in the CIFAR website, they have again a match tool, how to match the barriers identified in the CIFAR to the ERIC strategy. And there are some published literatures on its use. I didn't use it before. I'm not sure how it's useful, but again, online tools for your consideration. And we also have some systematic reviews from Cochrane to identify popularly used strategies that we can consider, reminder, audit and feedback, and local opinion leaders that we maybe in our choice of strategy, we could prioritize those strategies. And when we develop the strategies, we should also have some practical considerations: affordability, practicability, effectiveness, acceptability, side effect, and equity. So overall, develop implementation strategy is a complex and sometimes challenging part. Even for implementing scientists, this is one area that we are trying to research on. So definitely there's no right approach to doing it. We can think of how to combine our QI approach with the approach in implementation. But the key message here is we have a lot of online tools. We have a lot of existing tools and techniques to help us to give us some assistance. So when we develop it, we could consider those resources to co-develop with our knowledge users, with our staff and patients. So that's a key message for this step. And then how to measure behavioral change. The key question we want to answer at this stage is, did the people change their behavior? if we remember the AACTT framework I mentioned at the very beginning, we specify a not of for the hand hygiene, we specify multiple behaviors from the physicians, from the cleaning staff, from health administrators. So at this stage, we should also collect, if we specify that, it's easy for our evaluation outcome. Did the physicians change use the hand hygiene practice? Did the clinical staff timely refill the hand hygiene? Did the health administrator buy those hand hygiene gels, etc.? So they're all connected. So only when we specify those behaviors can we precisely evaluate did the people change their behaviors. We also have some frameworks like the REAIM framework or the Proctor framework that provides us some specific dimensions on evaluation. I won't expand here, but I want to particularly mention one key aspect that we might neglect in our no matter QI or implementation work, is sustainability. It has been the most significant translation research problem of our time. And some literature shows that up to 70% of organizational changes fail to survive in the long term. So we should always think about sustainability at the very beginning of our QI project. Always ask, is our QI initiative able to sustain? How can we make it sustain? And it's already, I should say, quite a well-developed field in implementing science, a lot of theoretical frameworks, a lot of tools that we can refer to help us to promote sustainability. Here I provide one named Sustainability Assessment Tool. It has 3 domains: staff, process, organization, have 10 categories, which we can analyze whether it's sustainable from those 3 category 10 constructs. This is not only a framework, but also assessment to a scale. So in those 10 domains, it has 4 different categories. So the total score for these 10 domains are 100 points. We could assess in each domain what are our points at each of those domains, so that we can clarify, okay, maybe this is the visible benefits part that we need to focus on in our future work, so that to make it sustainable. So we could do it, use it as an assessment of sustainability and inform our future work, which part we need to particularly focus on. And also one simple tool to assess its sustainment. Here is an established measurement tool with only 3 questions to help us to measure the sustainment of our QI work. Only 3 questions, easy to perform. So key message, there are quite a lot of useful surveys or tools, well-established tools that could help us to evaluate outcomes. Not only, as I mentioned, about sustainability, like not quite tools like scalability, like leadership, different dimensions, different tools that we can draw on. So here, another model that named implementation research logic model that has been also popular in implementing science, that could summarize all the previous work we are doing in implementation. We could summarize our determinants, or we see barrier facilitator here, and collect with implementation strategies and the mechanisms that why it can make change, and the clinical interventions that what are the effective interventions that we could draw that we want to implement, and it leads to what specific outcomes. So we could also use this logic model into our QI work, map our. I think this is also applicable in our QI practice. Lastly, complexity science lens. So I'm also strong, very interesting complexity lens. Here's one quote from WHO. They mention that every intervention from the simplest to the most complex has an effect on the overall system, and the overall system has an effect on every intervention. For example, even for just as I mentioned, the hand hygiene initiative, it seems such a small QI initiative, but involves multiple behaviors. And when we try to change something, it's always a disruption of our established healthcare system. So it's always a disruption. So we should always be cautious about doing some big change initiatives. Some key principles provided here are that first, act scientifically and practically. We should not only draw on the evidence in our literature, but also our context, our practice-based evidence. And we also need to engage with our launch users and empower them to have like local ownership and embrace complexity, recognize the uncertainty of our work and try to reflect and think it as an iterative process. So last thing I should say, we got in our QI work, dream big, but start small. Start with some small work and gradually expand. Small change can make big impact. And last, some resources I strongly suggest you to take a look at. One is the Center for Implementation Research at Ottawa Hospital Research Institute. At their website, they have multiple video resources, give us very systematic and detailed instructions on how to do implementation work. So they have several sections, introduction to knowledge translation implementation science, and creation and synthesis. Then, as we mentioned, each step, first is who needed to do what differently to promote implementation, identify barriers, and choose strategies, have very detailed introduction of each step I mentioned in the presentation. And then the practice knowledge translation workbook. You can see this publication and it's in their additional file 3. This workbook also give us step-by-step guidance on how to do implementation. What's in each step, they have a lot of resources to give you instructions. And then the Center for Implementation, in their website, they have online training, they have services. I think they also have a lot of tools. Yeah, you could definitely will scan their website. A lot of useful and very practice-oriented resources that can be used by our clinical staff. Okay, I think that's my presentation today. Thank you for your listening.
Thank you so much, Cheng. That was such a great presentation. I certainly learned a lot. And good morning, everyone. My name is Christy. I'm a Knowledge Translation and Implementation Coordinator with the Waypoint Research Institute. Some of those buzzwords Cheng talked about at the very beginning. So I'm going to facilitate a bit of a Q&A. Please feel free to add your questions into the Q&A box and we'll get to them. I just wanted to go back to a comment in the chat that was asking about confirming the difference between implementation science and quality improvement. So it's a question statement asking whether implementation science introduces the latest evidence and then quality improvement integrates that evidence into practice.
Yes, I think it's just different perspectives. As I mentioned in the similarity and differences in implementation and improvement science. So implementation science is often, sometimes we find a delay in our use of research evidence. Our work is to try to facilitate the use of evidence. But QI work sometimes more about we find a gap in our clinical practice, quality concerns, safety concerns in our clinical practice so that we do the work. But definitely it can also be used when we find some more useful evidence so that we want to bridge the gap. I think there are some nuances between them too, but definitely we can use the evidence into our practice as one part of quality improvement.
The next question is, at what point in the research process do we need to decide which tool or tools we'll be using to tailor implementation strategies?
To tailor implementation. I think here one term I didn't mention in my presentation is about tailoring implementation strategy. So first, I should say that developing implementation strategy is a little bit different with tailoring implementation strategy. My understanding of tailoring is that we have some, I should say, well-established implementation strategy in other setting, maybe in other hospital, in other organization. We want it to be used in my setting, so we consider to tailor it based on our local context. We have some methodology in this aspect on how we do the tailoring, what kind of steps we can do to tailor. But I didn't cover in this presentation, but it's also a lot of literature in implementing science on how to do the tailoring. But I guess here is their question might be, at what point do we decide to which tool to use to develop implementation strategy? I think at the very beginning of our QI initiative, we might develop a proposal of our approaches, of our planned approaches of doing the QI or implementation, but definitely as I mentioned, from a complexity perspective, sometimes it's uncertain, it's complex. We need to address emerging situation based on and adjust our strategy, adjust the tools to be used. And I guess sometimes, for example, in using TDF or COMBI framework, sometimes very challenging for our clinical staff without any knowledge of behavioral science. It's difficult for them. When some people use it, clinical staff, they feel difficult, they may decide to switch it to safer. That's more, I think, easy to understand. So I think it's always an reflective process, iterative process. But we lead some planning at the very beginning, involves not only planning stage, but also considering the sustainability.
Great, thank you. And I think that ties in nicely to the next question about, can you combine existing techniques and tools to determine strategies for implementation?
Yes. So I wouldn't say combine existing tools, but combine existing tools with our clinical expertise, with longitudinal expertise, their practice evidence, practice knowledge, practice wisdom. So sometimes we could see that the techniques, like for example, from the behavioral science aspect, like those online tools I mentioned, they are from behavioral science aspect, while the ERIC taxonomy is more general from maybe from the social science. Sometimes they are from different discipline. We do not want to complicate the process, try to combine them, but more importantly, combine one of the existing tools with our clinical knowledge, with our clinical wisdom. Yes, this kind of combination rather than combine existing tools.
Yeah, that's great. It sounds a lot like talking about co-development, like you talked about in your presentation, and collaborating together to find solutions. So I can answer this question. Yes, we will absolutely share the slides, and the recording will be available on Waypoint's website after this presentation. I did just want to briefly ask, and we'll leave it open to maybe 1 or 2 more questions, but you touched on sustainability and how important that is. And a figure that really stood out to me was that 70% figure. I'm wondering if you can briefly mention some things to consider from the beginning about planning for sustainability when you're first thinking about implementation.
That's really an important question and aspect. So if you remember the sustainability assessment tool, I mentioned that 3 categories: staff, process, and which the other, I think. So the 3 dimensions. Wait 1 moment. Yeah, 3 dimensions: staff, process, and organization. So when we initially plan our QI initiative, we could consider from these 3 dimensions and the 10 constructs to consider whether we have like sustainable resources to support our QI initiative, whether we have maybe it involve funding support, whether maybe it involves leadership support. We should consider those dimensions at the very beginning. If we like we only like maybe the organization only support the initial stage, provide the resource at the initial stage, and we do not consider provide further funding or resources, we may consider very difficult to sustain. So consider those dimensions at the very beginning. Yes, the 10 dimensions.
Great, thank you so much. So I'm not seeing any other questions. I would encourage you to reach out to Zhongcheng directly if anything comes up after the presentation. So I'll move us into our closing, our final housekeeping pieces, and we can wrap up. So just a reminder that the recording and the slides will be available post-event on the Waypoint Research website. And we do really appreciate folks completing our survey that will be sent out after the event. It helps us tailor our upcoming sessions and helps us to improve future Waypoint Talks events. We also have attendance certificates available for professional development. So I'm just going to send a message in the chat of where folks can reach me. I'm happy to create a certificate for you, and we really appreciate you attending today. So again, thank you for joining us. I did want to promote our event in March. We're very excited to have Dr. Brandon Sparks joining us from the UK, and his session is entitled Why Incels Are Worth Talking About. So quite a different tone from this session, quite a different subject matter, but equally interesting. So I'll share the link in the chat where folks can register for this event. And with that, I would like to thank you so much, Zhongcheng, for such a wonderful presentation. Thank you everyone for joining us today, and have a wonderful rest of your day.
Thank you. Thank you. Bye-bye.